But I'm going to go through the pros and cons as far as the two procedures are concerned, and particularly fusion doesn't have a lot of additional pros compared to an artificial disc, just because the nature of the surgery being a fusion. That's where more of the cons come into play, or the problems with it. So we're going to talk about the two different options, okay? ACDF, which is anterior cervical discectomy and fusion, okay? Basically, that's where we're taking out the disc and putting a piece of bone in place where the disc used to be, and then a plate on front to immobilize it. You know, kind of like we put a cast on the wrist when somebody breaks a bone. We kind of keep it still so it helps the bone heal a little more successfully and thoroughly. Also helps with pain control afterwards. So that's the reason we use the plate in front. We used to do these surgeries without a plate and basically just put a chunk of bone and put them in a collar for 6 to 8 weeks. The failure rates of the fusion were higher because there was still some motion there, and bone doesn't like to heal where there's motion, okay? But it's been around for 50 years. We have known downsides because if you fuse the level that you did the surgery at, right, the level above and below have more work to do because you've lost a motion segment. Now they've got to pick up that responsibility and pick up the slack. Well, the problem is that those levels start to move too much and have too much responsibility and can wear out faster and then have problems on top of that, okay? So we know that there's increased range of motion or wear and tear degeneration at the level adjacent or the levels next to where you've had the fusion done, so the level above and below. You can already see on this patient there's a little bit of wear and tear there already as far as some arthritis and bone spurring forming. Well, now that you've immobilized this level, you can bet that's going to have more of a problem sort of maintaining its normal responsibilities, let alone more responsibilities, because that level next to it doesn't move anymore. Okay, reoperation rates much higher with cervical fusion as opposed to using artificial discs, and you'll see that in some of the other statistics. So the Mobi-C, this is the overview of the independent device exemption, or basically the way to get approved through the FDA. So they did a study with 600 patients. So for every 2 artificial discs, they did 1 fusion. And the reason why they don't make those even is because we know what to expect with ACDF. There's a plethora of studies that are out there to tell us what's going on, right? So we put 2, so we have more data with artificial discs to work with than we do with the fusion, so we can have a better comparison or have more data to work with. So we looked at 2 years out, which is a primary endpoint of 24 months, and eventually FDA approval was achieved in 2013. So this has been around for 5 years as far as in the U.S. as far as approval is concerned. And obviously the idea of this is to maintain motion at that level so that the levels above and below don't have the additional responsibilities like they would with a fusion. All right, just to give you an idea, it's kind of a little, everybody likes watching movies, right? So that's what we're going to do here. Just to give you a sort of cartoon version of what it looks like, the 2 different procedures. So this is what it looks like implanted in the spine. There's a metal implate above and below, and then a polymer spacer in between. That gives you an idea of it sort of ex vivo or outside the body. So maintain your range of motion, flexion extension, lateral bending. And then you take that in contrast to what a fusion looks like, you'll see the difference. This is not going to move, right? So you're going to have the discs above and below responsible to try and compensate for that motion that's been lost with that fusion. All right? And over time, that has its effects, takes effects, because you obviously move your neck quite a bit for everything you do on a daily basis. Same sort of thing with lateral bending. You'll see the deficit in the range of motion or the differences. So that margin makes a difference, like I said, over time. All right? Okay, so if we look at what the study demonstrates as far as adjacent segment degeneration, this is wear and tear and wearing out of the levels next to the fusion or next to an artificial disc. So the green, this is a one level study here, a 2-level study. So this is just a single level. Artificial disc is in green, okay, and the fusion is in blue here. Okay, this is the level below and the level above, and you can see how much more wear and tear, or there was problems above and below. So 21% versus 7%, so 3 times the rate, and then here about almost twice the rate as far as the level above, as far as wear and tear problems. Now at a 2 level, it becomes even more profound, right? So the level below, 6 times the rate of adjacent segment problems or wear and tear at the level below. And then with the level above, about 2 to 3 times the difference. So when you start having multiple levels, and this is approved for 1 and 2 levels, you really start to see the compounding effect of maintaining motion at these disc levels in our spine, okay? Then surgery is required at the level next to the injured level or the previously operated level within 2 years. So with the artificial disc, 0.6%, 3.7% for fusion. Artificial disc in 2 levels, about 1%, almost 4% in the fusion level. So there's obviously a dramatic difference as far as the statistics are concerned. So secondary surgeries at index level, that means have to go back and refix the same level. So this would typically be for a fusion because it didn't heal, okay? So obviously an artificial disc, pretty rare to have to go back in there unless it subsided, moved out of place, it wasn't put in correctly, or if the bone was too weak to hold it, or if there was some other issues there, or even an infection. But in a fusion, you see the rates again are quite a bit higher for both 1 and 2 level studies, okay, as far as the reoperation rate. So that's just adds a lot of grief to the patient's life if they have to go back in and have a second surgery when they've already had this attempted to be fixed once, right? Plus the scar tissue outcomes aren't as good. Those things just go inherent with a secondary surgery. So FDA overall trial success, 1 level and 2 level. So this is the artificial disc, 73%, 65% for the fusion. That's including improvement in neurologic function, radiographic success as far as healing, and then secondary surgeries, how many patients were able to be treated without having to have a second surgery. So a pretty significant difference there. And then second, for a 2-level arm of the study, you can see a dramatic difference, 69% versus 37.4%. So these patients have morbidity or problems after surgery that continue because you've had to permanently alter their anatomy. So we go in and fix the problem, which is usually taking the disc herniation off of a nerve, which is generally why they're having surgery. And then you're having to permanently alter their neck by fusing them together. So now they're not where they were before they had the surgery, before they had this problem, right? They've had a permanent change where they've lost some function in their neck. But with an artificial disc, we can avoid that, all right? So here's going to be a video of what it looks like actually in a patient in the operating room. So you can see how this thing moves. So it's 2-level intraoperative, and you can kind of see the discs moving. So you just watch the orientation of the end plates. See how this one's sliding back, and then slides forward, meets up again. Same thing with the angulation that's going on at that level as well. So it's just the idea, proof positive, that the thing does move, and we can see it actually in motion or in action, okay? As far as what the artificial discs look like. Now return to work. Pretty interesting question, right? So I've been doing these now, it's been 3 years? Is it 3 years?
At least.
Yeah, so I think it's been right around 3 years, maybe a little bit over that. What I've noticed with artificial discs, patients, well, they don't need to wear a collar, right? Because it's not a fusion, we don't need to mobilize the bone. In fact, I don't want them in a collar because I want them moving right away. I don't want this getting scarred in or even bone forming across it because, believe it or not, once in a while, a great while, you'll see if patients are really arthritic, the patients have had that done, they'll actually fuse across that level. So they're usually not candidates for this, and that's one of the contraindications to doing the surgery. If they're really arthritic, have a lot of bone spurring, you have to go in and clean out these bone spurs, put an artificial disc in. With the bleeding bone and all that bone trauma, the body thinks there's a fractured bone here, we have to fix it because of all the trauma that went from just surgery itself, and it'll actually grow bone right across the implant and cause it to stop moving. So most of the patients, and the key here is, in the younger population, generally our workers' comp population, right? These are younger working people. They're usually not heavily arthritic. There are occasions that they are, but usually they're younger working age groups so that they are better candidates for artificial discs. And that actually bodes well for them for multiple reasons. One, we're able to get them back to work sooner. Okay, they can get back to quality of life sooner because we don't need to wear them in a collar, or I should say they don't have to wear a collar. We don't have to then institute physical therapy to regain that motion that they've lost because they were in a collar. So they've got the stiffness that is become a problem because of the collar. And they have less long-term problems with this because now we haven't fused their neck or portion of their neck together where they have issues above or below that and start having other issues because of pain at the other disc levels, right? So if we looked at the 1 and 2 level study as far as the FDA study was concerned, so typically Mobi-C return to work for a 1 level, it's 29 days, ACDF 36 days, okay? So you're talking 4 weeks to about 5 weeks. 2 level study, 6 weeks to about 9 weeks, right? Almost 10 weeks. So there's a big difference when you're talking about getting back to work as far as maintaining their function and getting back to their quality of life sooner. We don't have to wait for the paint to dry. We don't have to wait for this fusion to happen to start them rehabbing and getting back in their line of work and start the recovery process. Because that's what you kind of have to do. And I always use this analogy in the office when I tell patients, because they have a fusion done, you fix the problem, they have a fusion, whether it's neck or lower back. I always analogize that to building a house. You pour a foundation, you can't start putting the framing up or the 2x4s and framing out the rooms if the foundation's still wet. You have to wait for the cement to dry, right? So the concrete's got to dry before you can build. Same thing with fusions. They've got to heal the fusion first before you can start moving and stressing and rehabbing them, because you're going to cause the surgery to fail if you start moving too soon. Well, with artificial discs, we want them moving right away because we don't want it to stop moving. We want that thing to keep working and keep doing what it's supposed to be doing, and that's motion, all right? The one downside that I've seen with this is that I think the patients have a little more pain, neck pain, following surgery than they do with a fusion. Because if you think about it, we put a plate in there and it holds everything still. Well, the pain and the irritation subsides really quickly because things are immobilized. It's like why you put a cast on a wrist. It doesn't hurt anymore because you keep the bone still. Well, now we just operate in the area of the bones and the disc, and right away we've got to move. And that's like having a broken arm and starting to work the arm. It's going to be a little painful for a little bit longer in that regard because now you're moving a freshly operated level and something that you've repaired. So their neck pain can persist a little bit longer. You just have to adjust for their restrictions in that regard, knowing that that's going to be the case. But looking at them driving, usually if the surgery's on a Wednesday or Friday, they're driving the next week. As opposed to a cervical disc, discectomy fusion, it can be 2 to 6 weeks as far as before they can get back to driving. So there's a big difference there as far as being able to mobilize and get around. So there's big differences in that regard as far as getting them back to their quality of life. All right. So the discs are in between, okay? There's these brown foam structures here, the bones, and this is the anterior spine, obviously. Okay, and basically the structures we're worried about are the discs in between and decompressing or unpinching the nerves, which are typically in the corners. And you guys can see where this probe's coming out right through here and right through there. And in fact, the nerve root's about the size of this probe, okay? It's about a little smaller than your standard, soda straw. Okay, and it comes right out of that hole right where you see the probe now. Can you guys see that? Well, just inside that, right in this corner, is where the disc material is. And that disc material can push out. Can you kind of see where that probe's coming out there? Well, that's where disc herniations cause a problem and pinch the nerve that's trying to come out at that area, okay? So what we need to do in order to get there safely, and a lot of times it's not just in the hole, it's even larger than that or more broad-based. So it's even up against the spinal cord and where the nerve roots are. All right, so what we do is we go through the front and we end up sacrificing the disc, pretty much the whole structure of the disc, in order to get to where the problem is. It's a small incision in the front of the neck, about 1 inch wide. It's horizontally oriented. And once we go through the skin, there's nothing else to cut because the tissues in the neck are all vertically oriented. And so we just spread them apart to get to where we need to get to. We don't have to cut anything else, and then you have the cervical spine right there. So that's another reason why the anterior approach for the neck is a good option, because it's not real traumatic for the body's tissues, all right, as far as recovery goes. So typically what we'll do is we'll have different instruments. I'll give you some of the examples. This is called a pituitary. It's a little grasper. Okay, and it basically just goes in, and the idea is just to bite out the tissue, okay, and take the disc material out. Okay, and this is all done either through a microscope or we have microscopic glasses on so we can see, the picture here much more magnified, even more than you're seeing obviously on the screen up there. And that the purpose of that, obviously, we can see the neural structures and we can see the delicate structures we need not to injure while we're working on it. Neuromonitoring, you guys know about neuromonitoring at all? Okay, neuromonitoring is a procedure where we put little needles or stickers on the body, and then there's little corkscrew pins that go in the scalp, and we send electrical signals through the brain and out the body, out the extremities. And a computer watches those signals while we're working to tell us if we're getting too vigorous around a nerve, it's getting irritated, or the spinal cord doesn't like what we're doing. It starts to pick up on that in a very sensitive way, so we know we need to readjust what we're doing or how we're going to get there, wherever the problem is. So for instance, if you have a disc herniation and it's up behind the bone in the back, and you can't get there with a probe, or because the canal's a little bit narrow and a probe back there's trying to get the disc out, and all of a sudden the neuromonitoring tech's like, the spinal cord's getting irritated, we know we can't do that. So then we'd have to take off more of the upper portion of this bone, okay, like the upper third of the bone here with a burr or different tools, so we have a bigger window to work with and get to that disc without having to push the cord out of the way or cause any irritation of the neural structures, okay? Okay. So that's what the disc looks like coming out, okay? And then once we're in there, we use these smaller instruments called Karasons. You guys can see this. So if you look at it from the side, you see how it's a punch that has a flat plate on the bottom? Okay, so that structure goes on top of the, so if this is a nerve root that's in there, it goes on top of the nerve root, okay? And then we can slide it underneath bone or disc and bite off that piece while protecting the nerve root underneath it. So that's what a Karason punch is. This is probably one of the most important instruments we use in spinal surgery because it allows us to protect the structures we don't want to injure and take out the structures we do in a safe manner, okay? So then a lot of times we'll come in the corner here with an instrument like this and then wiggle this to where it needs to go and bite off some of the tissue as far as getting out the disc or if there's any bone spurs out in that corner. And then sometimes we'll actually use probes like this one, but it'll have a little right angle at the bottom, like a little side portion to it that we can go out there and pull out some of that disc material and then take the pituitary and pull out those disc fragments to make sure that we have a nice clean nerve root. And then that same probe that's bent, and I'll bend this one just so we can see it, kind of like a 90 degree like that, we'll then take that and make sure that that can go cleanly outside that passageway there, that nerve root's not getting impinged anymore. We can feel around it to make sure everything's wide open around that nerve. So we know we got the nerve unpinched now. So that's actually the purpose of the surgery, right? We want to unpinch the nerve. Well, now what do you got? You got to fix the damage you caused to get there. And that's what we're doing in surgery. We're causing injury to the disc because we're removing it. So you have to replace it with something. And so that's either using a bone plug and a plate or an artificial disc, okay? So I'm going to remove the disc above real quick so I can show you both versions of it. Okay. So now that we've taken the disc out and unpinched those nerves, okay, the two options are to use what's called a cage, okay, and it's a spacer that's kind of this trapezoidal looking thing. This is the inserter, but what's left in front of my fingers there is the cage, kind of that trapezoidal square there. And what we do with that is because we're taking out bone spurs and we use it like a high-speed burr or drummer or like a drill, and we rough up, this is for a fusion now, we rough up the undersurface of the bone on the upper bone and the top surface of the lower bone, so the two end plates. We take this burr and we rough that surface up, and what that ends up forming is basically bone dust. You know, like sawdust when you use a saw on wood, you have sawdust. Well, when you use these types of instruments on bone, it produces like a bone dust or bone debris, and there's always a little bit of oozing or bleeding there, and then that basically mixes with the blood and forms like a putty. And then we take that bone material and we put it inside the hole or the aperture of this cage. So we fill this thing up so that it's completely filled and level surface with the two surfaces of this cage. All right? And the reason why that's a good idea is because it's their bone. The body recognizes its own bone. It's the best bone there is because it's its own tissue. All right? So once we have that filled with bone graft and we've had our decompression done, we're going to take this spacer and put it inside where the disc used to be. Okay? You guys see that? So that's called a cage. All right, that's an interbody cage. A cage just means a spacer that has the bone graft material inside of it. And then once that's there, we have screws here, Mark, for the plate. Okay, that's fine. So then we use a plate. If you guys can see this, it's kind of about the size of a postage stamp. Okay, and that basically is a one-level plate. If you add a little more length to this and two more holes, then you have a two-level plate. Okay, so this is just a one-level fusion plate, okay, or ACDF plate. So we'll put that on the front of the spine. And there's other tools that hold these things in place while we're working. We got 4 total, hopefully. Plenty where those came from. Plenty where those came from. So that's what it looks like when we're done, okay? So there's a plate holding the two bones above and below the fusion, and that immobilizes that level so it can heal together, okay? But obviously the problem there is that doesn't move anymore. These two bones are basically now one bone, okay? So that motion now has to be taken up by the discs above and below. As opposed to, you can grab that black bag out of it has an artificial disc model. You can take a look at it. Is that little nylon bag? Yeah, that's it. There should be one in here. You guys can pass this around so you can actually see what it looks like. And it's kind of magnetic, but you can see it moving. So as an alternative, we have an artificial disc here, okay? And you see there's motion involved because it has three parts to it, okay? There's a metal end plate, which is the bottom end plate. There's a spacer that goes on top, and if you look, I'll try and show it to you. Do you see these two little pins that are here? Okay? Those pins constrain or keep this spacer or this bearing inside from going where it shouldn't go, okay? So it kind of locks it in place and allows it not to spit out or go where it shouldn't be. Okay, so that maintains its location, its positioning. And then there's another end plate that goes on top. And if you look, the shiny surface is the part that moves. It's supposed to be slippery and shiny. The back surface, you can see it's textured, okay? And that's where the bone actually grows into the metal. It grows in and attaches itself to the metal so this stays consistent. But then if you look on the side view, you can kind of see, you can see the little, that's not going to be focused. But do you see the little teeth that are on the edge here? You guys see those little, looks like barbs of a hook? Okay, that's what digs into the bone to give us preliminary fixation so this doesn't come out or slide out of place. Okay? So I'm going to use my makeshift inserter here. Actually, I think I just used the plate last time. This might be too big for this, but we're going to find out. Is the other model, the other anterior model here? Let me show you. This one may not move far enough apart. Yeah. So there's a secondary model, just has a little more room to get the, and these are in different sizes, so we pick the correct size that fits the patient's anatomy, okay? Okay, and then once we put that in place, we basically are done, okay? So now you can see that these bones can still move with the implant in there. Okay, as far as an artificial disc is concerned, as opposed to losing that motion with the fusion. All right? Any questions?
What is the price difference?
It's actually, the surgery itself is cheaper, like the CPT code 22856 for an artificial disc is a lower cost than it is actually for a cervical discectomy and fusion. And so it is for the facility fees as well. So it's actually a cheaper procedure overall. What about implant costs?
Implant cost depends on the hospital, but the OBC is typically a little bit cheaper.
A little bit cheaper? So it's even cheaper implant-wise, too. So this is all music to your ears, guys?
Yes.
Okay. It's always a good thing, right? Well, that's technology. We're trying to make things cheaper. Patients do better outcomes, shorter recovery times, and that's the whole objective of things. It's a win-win for everybody, right? So that's what the anterior procedures look like, either a fusion, discectomy and fusion, or artificial disc replacement, okay? And then I'm going to show you what the posterior part looks like as well. So this is the front of the spine. You know, we removed the disc. Well, there's still ligaments on the side, and I usually leave the ligament that's in the back of the disc. I leave most of that ligament intact because if I don't need to be taking it out, and my disc is on one side, I don't touch any of that because there's no reason to do that. It's just more injury, more damage, and more problems down the road. So you find with spine surgery and probably a lot of surgeries, you need to get in and get out. Get in, fix what you need to fix. Don't do anything more than you need to do to get the patient their best outcome, right? Lower time, less trauma, the tissue's healing up. But as far as like dislocations, things like that, we haven't seen any issues with it. But looking, so that's the front of the spine, and then also you have ligaments in the back and the capsules, the facet joints in the back that also impart stability. So these are the shingles of the lamina that are posterior, and this is the spinous prostheses. Okay, so typically if we're going posterior, usually it's because the anterior discs are almost autofused, and going in to clean out autofused discs is not a real lot of benefit. Or if there is trauma, we have to go in the back, or if there's a posterior problem, whether it's soft tissue injury or if there's bone spurring that's causing some problems or pressure on the spinal cord, we want to get a big caliber, big canal for the spinal cord. So the way we do that is we unroof the back of the spine, similar to what we do in the lumbar spine, by taking off the lamina back here and taking the spinal canal and then just making it bigger, okay? And so the way we do that is these instruments I showed you. Do you have a 4mm Karason, or is that up here? No, there is. Is we actually use that Karason, and I was mentioning to you how we go underneath the bone with that, and the neural structures are underneath that. So sliding this under the bone protects the spinal cord underneath, but we're able to bite through the bone that we're trying to get rid of, or the unroofing the canal, by getting rid of the tissues above the spinal cord or on the posterior aspect of the spinal cord, okay? And usually in surgery, what I prefer to use wouldn't be this punch. This is one way to do it, but obviously it takes a little bit longer, and I'm not a big fan of putting too many things inside the canal where the spinal cord is. So we actually use in surgery quite often is that Dremel or that burr, okay? And what that does, we're able to, from the surface, slowly work our way and grind down this bone surface and keep making shaving cuts through the bone until we get to the ligament that's underneath it. And there's always a ligament underneath it called the ligamentum flavum. So as we're burring through that, we can see this change in the color of the tissue from white to yellow, and we know that's the ligament. So we've got that buffer or that protection for the spinal cord. And the beauty of using the burr is we don't have to put anything in the canal, and it's a very controlled entity. So we can just take our sweet time and slowly eating through the bone until this back lamina of this has been removed. So I'll move the one above here too as well. And so typically, if we're doing a fusion back here, I'll show you where the screws go, but it's going to be in these bony areas here. We're going to rough up the outer surface, kind of where this is touching here, with that same burr, that same tool. And then these pieces of bone that I'm taking out with this tool, or even that bone dust I had mentioned before, when we use the burr, that Dremel. Okay, we're going to use that same bone dust to put and lay over the edges of these bones here so that they heal together, okay? Okay, so there's the lamina that are off. So now the spinal cord is typically sitting where the Karason is here, okay? And so what we've effectively done is open up the canal, or the back half of the canal, to make a much bigger canal. So basically something that's been tight, we just opened up the back portion of it so the spinal cord can float away, has plenty of room for plenty of space there for existence, as opposed to being pinched by the structures that were around that area, okay? So a lot of times what we'll do is, once we've done this decompression, we'll do a fusion, because the spinous processes that were here and the muscle attachments that are there keep the neck in a certain orientation. And if you don't do fusion, the neck will start falling forward because the muscles have nowhere to attach to anymore. So we'll connect these two bones together. So what we'll do with that is we'll drill holes in the corner here, and these are called the lateral masses, these square sections of bone on both sides. See if you guys can see that. Okay, and I've already kind of put some pilot holes in here. And then we'll put screws in those locations and connect them together. You guys can see that's what the screw looks like. So it's got a little tulip head, or like a saddled U-shaped head to it, and then a screw down below. And what we'll end up doing is lining up the U-shaped portion with the screw above, so we can put a rod inside that U, and then a little locking cap on top to connect the two together. Actually, got a rod.
Oh, yeah, sure.
I'll just show them one side. Maybe we can show the other bit. Yeah, one more screw, actually. I'll throw it in there. So then we'll line up the screws so that they line up once together, okay? these rods long enough?
I got plenty. No, 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 hold it. Oh, I've got longer. This is the next one up. That's 20, this is 30.
This may not be long enough. We'll see. Yeah, that might do it. So then we have a rod, which is this structure here, okay? And we're going to put that, just so they can see a little bit better. So we're going to put that in those tulip heads of those screws, okay? So that's how they would connect them together. All right, and then there's a little cap that goes on top of that. That basically secures that rod down to the screw head. Okay, so you see how that's connected now on that side? So the cap's on top and the rod in between. So that's where we do the instrumentation. And then we take that high-speed burr, that drill we were talking about, and rough up this outer surface of the bone, and then put the bone graft there. Okay. Now the question we usually get is, well, do you just leave that open where the spinal cord's exposed? Yeah, you leave it open. And the reason why is the tissue, soft tissues are, if we look at it from the side view, I can show you that maybe from the side view. So your skin and soft tissues are going to be way up here. Okay, so there's like 3 or 4 inches of soft tissues above the spinal cord. So the question is, well, if you get hit in the back of the neck, is that going to cause an injury to the spinal cord? No, it's so deep that the soft tissues protect it in that regard, so it's not really vulnerable there. And then the question is, well, what if there's a penetrating injury there? Well, the reality is, if you have a penetrating injury to your spine, it can still go between these bones as well. So it's always a risk no matter what, even if the lamina are there or not. But typically, we've not seen any issues with it.